You can
Yeah,
go.
first of all, I want to thank the organizing committee for their kind invitation. I'm very happy to hear about you from Mexico. I want to say hi to Julio Olvera. He's my good friend. And I'm so sorry because I'm late because of the last case, which takes a longer time to finish. So I want to talk about the combination of UBE with full endoscopy in some situation briefly. So the question is combined surgery is necessary? Yes, it's if you have combined stenosis or maybe sometimes needs to additional surgeries. And I think it's a good it's been good after especially two last speech. It was they were very interesting. The first is about the limitation of the UBE, and the second one is also related with the technical difficulties about the UBE technique. So after all, both of these the talk, then maybe my topic is will be very good. So mostly in elders, especially in elderly cases, the spine stenosis can be combined with the multi-location, and also sometimes the central stenosis can be combined with the lateral stenosis. Also, we see mostly in severe degenerated spine. So there are many different approaches for lateral stenosis. Mainly, we are using the two techniques, monoportal or the full endoscopic technique, and biportal UBE technique. Both of these techniques are available for the lateral surgeries. In transforaminal, we can do the foraminoplasties, fragmentectomy, SAP shortening, and also we can use this technique as a main component of the endoscopic stabilization. In paravertebral, in UBE, the paravertebral approach is also very nice. The technique, as we seen in the previous the speech, and we can do the partial facetectomies, SAP removal, sometimes discectomy, fragmentectomy, and also we can use this technique as a main component of the endoscopic stabilization. So, but why we are asking the question is it necessary or not, the additional surgeries in spinal stenosis? Because we've seen, in many cases, we've seen some unsatisfied results. If you look at these reasons of the unsatisfied the results, we can see that mostly we can see the wrong indications. If you have a wrong indication, of course, you will choose the wrong patient. So the patient selection is another reasons for the unsatisfied surgery. And also the other important reason is technique selection mistakes. And then surgeon-related reasons, especially in for the beginners, and also the patient-related reasons. We can list many reasons for this. The obesity, the osteoporosis, comorbidities, etc. And also, after all spinal surgeries, the postoperative patient management is very crucial. So if you have poor postoperative management, you can have unsatisfied results. If you look at the characteristics of the spinal stenosis, briefly we can talk about some pathologies can accompany the central stenosis. For example, intraforaminal pathologies. Mostly, actually, we have to know that the most of symptoms can arise from the lateral portion of the vertebra column. So the decompression means the lateral decompression. So we should decompress properly all the lateral components. The radiculopathy also arising from the lateral stenosis. And the access to the mid portion and far lateral of foramen is not easy from spinal canal, and it's true for all of the techniques, endoscopic, monoportal stethoscope, or UB. So mostly we need to additional surgeries. In UB, we can use the paravertebral approach, which is very effective. But if the pathology is alone, it's perfect solution for us. But if not, needs to at least 4 incision in same location. It means that if you have same the lateral stenosis with central stenosis, then you have to create 4 incision in same location. So it can cause more muscular damage, muscular edemas, and it can cause the facet joint injuries and the instabilities. We need the big skin incision, and also you have to make large fascia incision if you have 4 incision in same location. Look at this case. Now you see we have very severe stenosis, central stenosis. Also, if you look at this picture, we can see the also lateral stenosis and extraforaminal stenosis. Now, you can, if you follow this arrow, you can see we have a disc in the foramen. Yeah, we have to know that we have some unreachable zones for paramedian UB, like monoportal posterior surgeries. Yes, we can manage almost all the spinal canal, but we cannot reach the mid portion of the outer side of the foramen. So we have to know the unreachable zones for the from the spinal canal. If you try to make 2 surgeries for consecutive decompression, or if you want to make the pathway decompression instead of central stenosis decompression or lateral decompression, you can have to create like this incisions. You see, in a small area, we have 4 different incisions. We did left side central decompression with also left side paravertebral decompression. So what is the solution for this problem? So we can combine our surgeries. If you look at this first video, we're doing actually very well lateral decompression. As I said before, the lateral portion decompression is very, very important for solving the symptoms. Now we can try to, if you have more vertical facet joints, so you can go more ipsilateral. Also, you can use the 30-degree endoscope to see the ipsilateral upper foramen. even though perfect decompression, and also we can, of course, we can control and we can manage the disc pathologies. Then you will see the calcified disc. Now, I want to make further. Okay, then you see we did very nice decompression in lateral portion. There was a there was a calcified disc and lateral stenosis in this patient. Then we want to see the lateral border of the posterior long-tail ligament to be sure about the enough decompression. Now you see here we have a calcified part. Then you can remove by using the Kerrison punch, the calcified ligamentum flavum partially. Then we can manage the subligamentous disc fragments. Now, yes, it seems very nice decompression. Okay, also we have very severe disc pathology in the canal. Then now we are going to foramen by using the monoportal endoscope. I will make fast a little bit. Then you can see here the nerve root. Yeah, you see very severe disc fragments. Now we want to see the epidural space and the nerve roots. Now here is the epidural space. Yeah, here is the nerve root. It seems free. And also in cranial and in caudal side, the 3 o'clock is the caudal side. The 6 o'clock is the anterior side of the flavum, of the foramen. Then we seen the calcified disc in epidural space. Then we couldn't remove from the working tube. Now you see here the calcified disc. So we removed with the working tube together with the part, with the now it seems the free epidural space is very free and nerve root is okay now. So this is the first after first surgery. We did per-operative CT in our OR. You see, even though very nice decompression, when we checked the per-operative the CT, we see in the fragment. Then we removed this fragment from the paravertebral, the foraminal endoscope. Now, instead of two UB incision, I think it's the more acceptable. As a conclusion, UBE is ideal surgery for spinal stenosis, of course. In case of central plus same lateral foraminal or extraforaminal stenosis, paravertebral UBE approach is not enough for proper decompression. Adding paravertebral UBE approach offers a solution, but it has some limitation, which is talked about it. And then the combination of full endoscopic foraminal surgery is good option for same lateral foraminal or extraforaminal stenosis or disc herniations. Thank you for your attention. If you ask again, the first question is combined surgery is necessary. If you have combined stenosis, the answer is yes. Thank you for your attention.
Thank you so much, Professor Hayati. Wonderful talk.
And also, if you let me, I want to invite you to Turkey to join our International Spine Endoscopy Symposium.
Thank you so much, Professor Hayati.
Thank you very much.
See you in Turkey.